The next speakers, Efthimia Pantzartzis and Andrew Price, are both doing research in dementia facilities. Efthimia is at Loughborough University and part of the HACRIC group, which was a UK consortia of universities that I recall, and they're were able to do a number of projects. I know that Andrew says he's doing something to do with the Department of Health's building notes, which is a continuing development of the sort of guideline process. So they're going to tell us about dementia-friendly design principles and dementia-friendly core design features which emerged from a 12 months England improving the environment for care of people with dementia. So we'll hear from both of them in this. Thanks.
Good afternoon, ladies and gentlemen. I'm delighted to be given this opportunity to talk about some work that we've been doing over the last 24 months. Whereas HACRIC was very much about research, what we've been doing over the last 24 months is very much about implementation of those findings. The work that we've done has been funded by the Department of Health as part of their programme of developing design guidance and improving care for people with dementia. So the purpose of the presentation today is to talk about the £50 million programme that the Department of Health funded in England to improve health and social care environments for people with dementia. The initial programme was supposed to be 25 million for hospitals, but it was recognised that a major problem was with the social care environment, and so another additional 25 million was put towards that programme. This has underpinned the development of the health building note that we've been writing, and the whole programme of work has been funded over a 24-month period. And during that 24-month period, we selected 115 pilot projects out of 400 applications that came through. So the programme was 3 times oversubscribed. We then worked with the pilot projects over 24 months to deliver £50 million worth of capital works, and then we spent another 6 months drawing out the information from those pilot projects, looking at the benefits that had come through, looking at the interventions that they'd implemented, and we produced a health building note from that programme. When we selected the pilot projects, we made sure that the projects were innovative, and we were able to get a wide diversity in the projects, in the size of the projects, the type of the projects, the types of settings, and the type of interventions they were introducing. So I'm going to start off really talking about the context, and Maya's going to go into a little bit more detail about the process, about the programme, and the health building notes. The health building notes are available online, and so there's a lot more detail in those notes that you can download in the health building note, and we're just providing some of the details to go with that. An important aspect of developing these guidance was recognising that there's many different types of settings, particularly when you're looking at guidance that's associated with health and social care environments. And so we've worked out some of the key principles that we should be looking at and adopting. And obviously, in setting those principles, we are aware that people may need to modify these principles depending upon the context and the situation that they're dealing with. We've already had quite a few presentations that's been talking about the demographics and the statistics, but I'm going to just draw out 1 or 2 points to supplement those. We've recognised the ageing population, but a lot of the statistics that talk about the people over 65, and recognising that the number of people over 65 are outnumbering the number of children under 5. It's been said before, but I just wanted to reiterate that. One aspect of that ageing population, it brings a whole different number of comorbidities that come with the ageing process. It's very much the ageing process is a global challenge, but so is dementia, and that goes with that ageing process. So dementia involves a range of conditions. They tend to be progressive. People get worse in that process. It's irreversible to a large extent, and there's currently no cure, although progress is being made in that particular area. If we look at the statistics in terms of dementia, in 2012, it was 35 million people worldwide, and 2015 estimated at 47 million. There is problems with those numbers because a lot of people don't get early diagnosis of dementia, and therefore the statistics are improving as early diagnosis is improved. But the statistics are suspect to that variation because of the poor early diagnosis that actually takes place. So the current number of people living with dementia, well, effectively it's going to double by 2030 and triple by 2050. And it's estimated that if we look at the over 85 group, that 20 to 35% of those actually have dementia, even though some of those may be early onset dementia. So when we look at the demographics, one particular area that we should be looking at closely is those people over 85, as well as looking at the proportion of people over 65 that's increasing. This captures that a little bit more. If we look at the over 65s, again, we're talking about to 2050, we're talking about 188% increase in the 65 group, but in the 85 group, it's talking about 350% increase. So although we look at demographics and we're talking about the aging population, very often we're talking about the over 65, but when we look at the dementia side and look at the people that are in hospital, then we have to look very closely at the demographics of the group that's over 85. We do understand to some extent that purpose-built and purposely staff-built environments will impact on the quality of the care. We also realise that certain design elements, layouts, will improve the quality of care. But there's limited understanding of how and limited evidence that's directly related to the actual design elements and how those individual elements can influence the quality of life of people with dementia. And so within the health building notes, we've tried to draw out that evidence through the programme of work. In England, 22% of NHS buildings predate 1948, 25% were built between 1944 and 74. So not only do we have to make buildings and environments more dementia-friendly, we have other problems to deal with. One is the aging buildings as well as the aging population. In the UK, we've looked to save £20 billion in terms of spend within NHS, so we've had pressures to reduce financial spend as well as improve the care for people with dementia. And we've had several reports, the Francis Roll and the Keown report, again highlighting issues of quality of care, another issue that's been there. So the backdrop, although we're trying to improve conditions for people with ageing, we've got other problems within the infrastructure, which is the ageing infrastructure, and the financial pressures that's there. If we look at the costs of dementia, again in the UK, 850,000 people with dementia, again increasing quite rapidly to 2021. The current cost of dementia for the UK economy is estimated at £26 billion a year. A lot of that cost is associated with carers, informal carers, and the impact on family and friends, as well as the direct costs. In England, we've got 168 acute trusts, and they will have several hospitals, 8,000 GP premises, in 7,000 settings, and over 21,000 care homes that are registered and looked after. So when we're talking about improving the environments, then we recognise that there's a wide variety and a wide number of environments that we have to look at. So it takes a long-term strategic process to get these up to scratch and deal with them. Older people tend to occupy 70% of acute beds, and so again, as the aging population the age of the population increases, then it's really quite impactful on the type of people that are using the hospitals. And we also have to recognise that 66% of people with dementia are looked after in the community, so it's not just about healthcare, it's about social care facilities. So in recognising that particular issue of dementia, it was a national strategy back in 2009 for that particular government, and the Prime Minister launched the Dementia Challenge back in 2012. And part of that Dementia Challenge was the development of on the third bullet point there, is the Dementia Capital Programme. And that was a £50 million programme, and it funded 116 NHS and social care pilot projects. The diagram on the right is a map of England showing where those projects were. So the ones in blue tend to be where the funding for the social care projects were, and the ones in purple are where the NHS hospitals were. So there are some areas where they didn't get any funding, and that was represented in the actual quality of the proposals that they put forward, or they didn't put any schemes forward. So it shows that some areas are more aware of what's actually required than others.
Okay. This slide shows you the delivery plan of the program and tells you more about the methodology, which includes quantitative and qualitative research methods. You can see on the slide that we combine a literature review and pre- and post data on the pilot projects, together with knowledge sharing activities. On the program data monitoring, there were two types of data collections. One done monthly, which was related to the progress monitoring of the projects, so the actual works on the built environment, while the second one was done quarterly and was on the impact those interventions had on people living with dementia. The data extracted out of this, gathered through these activities, were combined with those which were only with activities which were planned for 30 detailed case studies within these 115 projects, and they were gathered and used to produce the final project recommendations report, which informed the Department of Health and the delivery board. Now, the key deliverables of this program were actually the innovative character of the pilot projects, the new knowledge and improved understanding of how these environments can impact on the quality of life of people living with dementia, the extensive rollout of the knowledge and best practices that were gathered throughout the program, and the encouraged and demonstrated benefits of the collaboration between health and social care workers and the integration throughout the dementia care pathway. Also, it supported cultural change and transformed care delivery, but also improved the environments, making them calmer, and improved capital gearing, resulted in capital gearing, because the £50 million that were provided by the Department of Health actually triggered more funding by different types of organizations, including also charities, and which amount mostly went up around 10 additional million pounds. So overall, the whole money that was used was around £60 million. The 14 core outcomes that you can see on this slide were actually part of the essential call requirements of the funding call that was put out by the Department of Health. So each organization that put a bid for this money had to respond with at least to one or more of these core outcomes with their own interventions on the built environment. And as you can see, they encompass the satisfaction of the needs of people living with dementia, both individual and collective. We can see improved privacy and encouraging independence, for example, but also the needs for staff and carers to enable a more effective and efficient service provision and delivery of care. For example, the 10, enabling people to be cared for in a comfortable and safe environment of their choosing. Now, this slide, Andrew has already explained that the program included different types of settings, different types of spaces, and different types of building components. This slide tells you a bit more on those. We can see that within the healthcare settings, there were specific interventions within hospital wards, but also interventions, projects that accounted for the whole hospital, and also for the integration of these environments within the community, the care delivered within the community. And this is on your left-hand side. On the right-hand side, we can see, similarly for the social care setting, the types of settings, so the variety that was within the program. So the care homes, there were day centers, hubs, integrated projects, which means across different types of settings, nursing homes, shelter houses, and the pictures are relevant to some of those projects. We can see an example of bathroom, bedrooms, and social spaces, living rooms and dining rooms, both for NHS and social care settings. The spaces. In this slide, we have colored in blue the NHS, the National Health Service projects, and in red the social care because it's traditionally the colors that were used. You can see the types of spaces that were mostly implemented during the program, and we can see as first one, gardens, so outdoor spaces, enhancing, strengthening what has been said already this morning in the need to provide a link to the outdoor environments and the green spaces. Also communal spaces, the areas, and circulation spaces, meaning that we want to keep the people active and to engage with other people as well. And bathrooms and bedrooms, equally, in order to enhance privacy and dignity of people living with dementia. One thing very evident is that there is not much difference between health and social care spaces. This next slide shows you more in detail the components that were implemented, and we have reported the first ones, which include flooring, color coding, signage, lighting, and again, equally between health and social care, there is not much difference. Similarly, the same type of components have been implemented. This meaning that these are felt more relevant to improve the quality of life and the well-being of people living with dementia. Also, artwork and technology were two big important elements that were implemented both in health and social care. The health building note, HBN 0802, dementia-friendly health and social care environments, was produced after this program. Loughborough University won the bid to deliver this document, and this is the first HBN intended to provide design guidance for both health and social care environments, because traditionally the health building notes are only for healthcare guidance. Again, the pictures are relevant to the projects, and there are some of them relating to hospitals and some of them relating to care homes, and you can see the variety of the types of intervention. The document itself was developed as much as user-friendly as possible, and the principles and the features were interconnected in order to allow ease of usage both for clinical users and technical users, such as architects and engineers as well, but also in order to enable people from the community to use them to improve elements in their own community settings and homes. So this is the delivery plan that you've already seen. The following step is we produce the first draft out of this, the data gathered during the capital program. The first draft of the document, we went through an iterative two-steps consultation process with experts on dementia from Australia, US, UK, Finland, and Norway. And then we produced the final draft, and that was submitted to the Department of Health of England, and it's available online. On this slide, you can see on the right-hand side all the types of interventions that were undertaken. So we started from the literature review, and then the pilot projects provided evidence to which spaces, which interventions, and which settings should be implemented because they impact on the quality of life of people living with dementia and can support a better integrated care delivery. All this gathered evidence was analyzed and was rationalized against the 14 core outcomes that were initially set by the Department of Health to produce the design features that I will show you shortly. So this graph shows you, during the program we asked to the pilot projects to rank the 14 core outcomes that they were asked to implement or to achieve, and to match what type of interventions, and I'm not sure you can read really them, but which type of intervention they have found matching or implementing these outcomes, enabling these outcomes. And we can see, for example, the yellow one, which is quite evident, is relating to signage. So it is quite important, as the blue one is related to fittings and fixtures, for example. Now, these outcomes, these 14 DH core outcomes, were better aligned to what are the impairments that people living with dementia might experience, and in particular sensory, cognitive, and physical impairments. So sensory, in all that enables them to collect information, all that enables them to process information, and all that enables them to perform physical activities. In doing so, some of them were translated, and we determined the 12 dementia-friendly design principles, the first of which is promote a safe environment, and actually it's an overarching principle because it includes safety consideration that can be valid for one or more than of these 12 principles themselves. But then the sensory, those principles that can enable to overcome sensory impairments provide optimal levels of stimulation, provide optimum lighting and contrast. Those that we found can improve cognitive impairments, I should read them, but provide non-institutional scale and environment, support orientation, support wayfinding and navigation, provide access to nature and the outdoors, we've seen, promote engagement with friends, relatives, and staff. And again, those that can can support to overcome physical impairments, provide good visibility and visual access, promote privacy, dignity, and independence, promote physical and meaningful activities, support diet, nutrition, and hydration. And this has been said as well today. Now, all this evidence has led to the identification of a set of core dementia-friendly design features that can be valid, as we have seen, because there is not much difference as well across different settings and spaces. And those design features were rationalized from those elements that were mostly implemented by the pilot projects. We have grouped them around construction elements, elements that can enrich the built environment, and technical elements. Of course, this is a core set that can be further expanded. I won't read all of them, but now the principles and the features were, as I was saying before, they were interconnected through a matrix that will enable both clinical or clinicians, designers, and end users as well to access this document and to make the best of it, because whoever wants to improve one of those principles will be able to identify which are the elements of the built environment that they might find more easy to implement because of availability of money or structure of the building or other constraints. And on the other side, when a designer is asked or is requested to implement one of those elements of the built environment, can more purposefully address what are the needs of people living with dementia. The structure of the document, well, this slide takes you into the structure of the document. So we have an introductory section on the policy and the scope of this document. As I said, because it's quite unique, it's the first document that encompasses health and social care environments, built environments. We felt that it was necessary to have a section on dementia types, stages, and prevalence, because some information might be relevant in order to allow recognition of what might work or not. We have the sections on design principle and on the core design features, and then a section on the strategic long-term approach and the benefits realization plan. But also we have two sections with detailed case studies, 4 on healthcare settings and 4 on social care setting, which were taken from the Dementia Capital program, but undergone further development. Now, an example of the document, the 3 sections, so the one on the principles, the one on the features, and the one on the case studies, have a particular layout. We have found that the principles, we will have one-page layout with the rationale and what the principle, what is needed in the built environment to enable the principle, the presentation. I have, don't go. Okay, this is the layout we designed for the design features, which is a 2-page layout in which we have an introduction to what the design feature is and some specific indication on the construction elements and photographic reference, and the case studies, which are 6 to 8 pages layout, in which the challenge is very described and how the interventions match 12 design principles. Just to finalize the presentation, the research has basically identified these 12 design principles that support the design of dementia-friendly built environments, health and social care environments. It's gathered evidence towards the systematic core of design features that can be purposely designed, and has delivered an evidence-based design guidance that is widely and freely accessible throughout the government.uk website. Person-centered care delivery can contribute to quality of life of a person living with dementia. A set of principles and core design features can be applied across settings, cross spaces, and also cross countries if we take into account the limitations. The gap between health and social care is reducing, but it can lead to optimum integration, and core features can support effective and efficient design solutions. Thank you.